everybody does a talk on ARDS. This isn't really a talk on ARDS, but Dr. Gong's is probably the definitive talk on ARDS. This is the files that I shared with you guys pretty much are the ones that she refers to. These are sort of the key articles plus a few more. This review in CHEST is very good. You know, it does not take into account some of the latest data on proning and the oscillator, but otherwise it's still very comprehensive. The CSER trial is here, as well as a review of ECMO and ARDS. One review article on elaprost and ARDS. This is the negative, the most negative of the two negative high-frequency oscillator trials. The two largest RCTs on proning, one of which was negative in JAMA, and the more recent very positive trial. And then just a review of vasodilators in ARDS. There's a few other articles that aren't in here that could be in here. The AccurAssist trial, which is in the basic modes of mechanical ventilation folder, is sort of a key trial, as well as the meta-analysis that Dr. Gong talks about of high versus low PEEP strategies, which I think is sort of a key article to see as well. Anyhow, there's also this this basic teaching file, and then the case scenarios, which is what we're going to do. And we'll use this. Anyone want to read? It assures that you're awake if you're reading. You might not be paying attention still, but you are awake.
Which of the following treatment modality has been shown to improve oxygenation in patients with severe hypoxia due to the acute respiratory distress syndrome? I'm guessing the answer is A, which is bulleted. High-frequency oscillating ventilation, prone position ventilation, inhaled nitrous oxide, ECMO, or all the above.
So I'm sorry about the dot. Somehow conversion from PowerPoint, Google Drive, it's pretty nice, because even if your computer doesn't have the latest PowerPoint and can't convert, you can like upload it, then download it to Google Drive, Google Docs, and then convert it to a PDF. But it's doing this weird thing where it's adding little dots and things. There's a few little issues with it, but I'm actually like doing word processor and Google Docs now. Should we buzz that? So any answers besides the one that's bulleted? So this is an all of the above, right? So it's basically, there's a lot of different modalities and that have been shown to improve oxygenation in patients with ARDS. Very few that have consistently been shown to improve outcomes. But it's reasonable, we have to have these modalities ready for us and have them all in the since we have all those options available here, you're not always going to be at a center that has all the options available, but you have to know what they all are and know that they can save you. Also, it's pretty rare that we have somebody dying of refractory hypoxemia per se. It happens. But we need to know that we have a bunch of different modalities potentially available. So of those modalities, the oscillator we have here, it's a very interesting mode. We'll talk about the evidence behind it. Very interesting mode, and I think it's going to end up being a sort of historical interest. We do have we have oscillators, they're used in peds and they'll bring them over. We have the old machine. It's super cool. It looks like Kit from what is it? Night Rider? Night Rider is so awesome. It's got like the back and forth red LCD display. It's super cool. It's awesome. So we have the oscillator available. We'll talk a little bit about that. You might or might not get to see it. They're trying to market. They have a new one that doesn't look as cool. That's like built recently. The people who have created this the Novalung company, who makes this ECMO circuit that it's like a pumpless ECMO circuit, and they're billing it for extracorporeal CO2 removal. And the nice thing about pumpless ECMO circuit is you don't need anticoagulation. It's actually AV ECMO, which we don't see here, but they do in Germany a lot, arteriovenous ECMO, right? So it doesn't need its own pump, and it's a membrane that's much easier to get flow across. It's really sort of been approved for extracorporeal CO2 removal more than the oxygenation component of it, but that may be all you need in some of these patients who are on low tidal volumes or patients on the oscillator. So their sort of vision of this is that we'll put patients on both, like a new oscillator plus this Nova lung. So AV ECMO, pumpless, no AC, and this new cooler-looking oscillator. You know, with the latest data coming out about the oscillator itself, I'm not sure how well they're going to be able to sell it, but it's interesting. And there's all sorts of case reports of people's, you know, who were dead, who were saved on the oscillator, or people saved on the oscillator plus ECMO. So, it's out there. Prone positioning, which we'll talk about. What do you know? Are you the consultant attending today? What? Spy?
Just slumming.
Slum. Slumming and Moses. Yeah, right. You're lucky we let you in here, man. Professor. Prone positioning, which we'll talk about, which we use infrequently, maybe too infrequently here. I don't know. That's up to interpretation. Inhaled nitric oxide, which we used to use a lot here, which we have available, which is easy to use but expensive, and will very frequently get you some bang for the buck, but it's overall very restricted. ECMO, which we, or as centers go, we use a lot of, and you will actually see. But the answer here is all of it. So the other things we could think of that improve oxygenation in the ARDS, anyone else? What are other things that we could do that have been shown to improve oxygenation? Let's say somebody comes in and they are coming in from the emergency room. They are in ARDS. They are sedated, but they're breathing over the ventilator. They're a little asynchronous with the ventilator and very hypoxemic. What's something that we frequently do? Is paralytics, right? So that will frequently improve oxygenation just by improving vent synchrony, decreasing work of breathing, which is decreasing your oxygen extraction overall. So your oxygen delivery on the next venous side will be better. And then there's these long-term outcomes where potentially there's mortality improvement due to less lung injury, due to less ventilator asynchrony as well. So paralytics are something we go to, and probably the data is suggesting we should be going to more frequently in patients in the initial phase when they are very sick with ARDS. What else? Other things that we do when we're desperate?
Instead of nitric oxide, we can use the prostacyclin analog.
Right.
And what else?
Right. So prostacyclin analogs are inhaled selective pulmonary vasodilators. Right. They vasodilate the well ventilated areas of the lungs, so they improve EQ mismatching and reduce shunt. And they've been shown to improve oxygenation. They're cheaper than inhaled nitric oxide, so that's why we prefer it here. They can help with patients with high pulmonary artery pressures, right? With right-sided heart failure, patients with patent foramen ovales. They're useful in as well. Same with inhaled nitric oxide, very similar. Other things. Methylene blue just popped into your mind. That was like free association, methylene blue. No, because we said inhaled nitric oxide, and then you said methylene blue. So methylene blue. I don't know. It's potentially. So.
That's in one of those articles, just like last page. So it's like,
so I didn't read my own article.
I think it was like, you know, the last few paragraphs are like,
right. So methylene blue is used for, we usually talk about it for refractory septic shock, right? Refractory to all over. But still no, there's a possibility, some of them worth looking into, right? So in profound vasodilatory states that are refractory to all pressors, methylene blue may work via mechanisms that are not well understood. Some of the vasoconstrictors may help with decreased DQ mismatching. There's some talk about some of them accentuating the hypoxemic pulmonary vasoconstriction. So same rationale behind the reason that some vasodilators worsen DQ mismatching and worsen shunt, because they inhibit hypoxemic pulmonary vasoconstriction, your usual compensatory mechanisms. So who knows? We got to try methylene blue. No, I mean unfortunately we never use it, but you could report in patients who are, though that once a year that we use it, it's probably less now, unfortunately, but see what happens to their PDF ratio when you give these patients methylene blue. So anyhow, it's interesting. Okay, question 2. Oh, sorry, other things we can do. Recruitment maneuvers, right? So recruitment maneuvers are useful, putting on patients on high PEEPs with a little bit of pressure support for 45 seconds or so, PEEP of 30, PEEP of 35 with a pressure support of 5 for 45 seconds. Personally, I don't do it unless the patient has an A-line in, so I don't tend to do it in the ER because the incidence of hypotension is so profound, so frequent, and it's so rapid that I don't feel like I can even tell if I'm making somebody hypotensive without an A-line, and that's my personal bias. Very frequently improves oxygenation. You have to remember that you're going to come back to a higher PEEP. You're going to come down on PEEP slowly afterwards, and since you've recruited alveoli, you're likely to want to stay at a higher PEEP than you started with. People who are recruitable tend, with a recruitment maneuver, probably also do well with higher PEEP strategies. And some patients are not recruitable. Patients who do worse during recruitment, patients who you're over-descending, you'll see that their oxygenation will get worse frequently. Patients with unilateral lung disease a lot of times will get worse with recruitment, can't tolerate recruitment.
So, I'm sorry. So with your recruitment maneuver, when you're doing like PEEP of 30, will you choose pressure support or pressure control? Because the reason I'm asking is because we were talking about this yesterday. Yeah. That if somebody takes a deeper breath on top of PEEP of 30, let us say, that might actually contribute to better trauma, right? So either is fine. If you're giving pressure support of 5 above a PEEP of 30, that's fine. The pressure's going to be 35 for brief periods of time. So pressure control. If you do pressure control. But pressure control, I will imagine there are less chances that they will take a deeper breath, right? The pressure support, they might actually, with even pressure support of 5, if their respiratory drive is too much, they might take a deep breath. So the actual transpulmonary pressures could be higher, but again, generally these patients have to be heavily sedated or paralyzed. And even on pressure control ventilation, you can generate higher transpulmonary pressures, similar to the way the patients on PRVC, when they suck in, are actually generating high transpulmonary pressures. It's not just the pressure that you're giving; it's also their own work that they're performing. So I'm not sure that pressure control is going to fix that. I think the main thing is that the patients need to be sedated and usually paralyzed. They're usually paralyzed before we get to this point. So,
Dr. Keene, what was that strategy? What was the that 2-level ARDS net protocol that Dr. Gong was talking about yesterday? The high PEEP, low FiO2, and high FiO2, low PEEP. Like, can you just explain like when we go to each one of those?
So, in general, what Dr. Gong is saying is that some of the evidence suggests that a higher PEEP, if you look at the ARDS net protocols, they will give you 2 different protocols: a low PEEP, and a high PEEP strategy. Just meaning high PEEP, just meaning for a given FiO2, a higher PEEP is recommended. That's all. And overall, the although there's no, there's essentially like 3 large RCTs, none of which showed a clear mortality reductions in the high PEEP strategies. When you analyze that data and look at the patients with severe ARDS or moderate to severe ARDS, there does seem to be a mortality reduction in that subset of patients. So what Dr. Gong is saying is that has sort of de facto become the standard of care, or it is to such an extent that in clinical trials they're now requiring that in moderate to severe ARDS that we use the higher PEEP strategy. So that, I would say, in patients with a P to F ratio that clearly seems to be under 150 and stays there stably, or under 100, something like that, I would tend to use the higher PEEP strategies. I don't think we do it enough. We used to, instead of titrating according to a protocol, we used to do it we do it on a patient-specific basis, where we would increase PEEP and look at what increasing levels of PEEP do to lung compliance. And we would do that until we got to an upper inflection point where patients clearly over-recruited. And so we used to, spend a lot more time sort of trying to figure out what the optimal PEEP is for a patient. And we don't do it anymore. It's probably a bit too labor-intensive, and there's too many things going on at once that it's sort of useful for clinical trials, but in reality, it's a thing that's kind of hard to do, and there's so many moving parts in terms of oxygenation, is the patient adequately sedated, hemodynamics, that it's always hard to say exactly where your best PEEP is. So going with a sort of protocolized approach is probably reasonable.
What about the use of the stress index?
Right. So that's
that as
you could certainly do that. I mean, you could certainly use any measure of lung compliance and at what area the lung is optimally compliant. I don't know. Have you used it before, or
very rarely enter a situation where I do use it.
Right. We've heard it talked about a lot. I did it a little bit in fellowship where we would plot out where a patient's lung compliance is at various PEEP levels.
Do that on the ventilator, Nader? Do you guys, is there like a way to just calculate compliance on the ventilator, or is that like, is this something you just...
You look at the slope of the, you can just look at the slope and on the pressure time graph, and if the slope is a straight line and it's equal to 1, then you're at optimal PEEP. And if your slope is concave up, then you are under PEEPed and you're concave. And if you're coming down on the slope, then you're over PEEPed, and so you should dial back. This is a measure of how much, whether you're over distending the alveoli or not.
Right. So we used to just do it on the actual pressure flow curve is how I'm.
Yeah, pressure flow curve with
on a pressure flow curve
with the constant flow ventilation, so on volume control.
Right. I think when it comes down to it, you're going to have some patients who are PEEP responsive and patients who aren't. And if they're PEEP responsive, it's probably better to use the higher PEEP. More severely ill and seem to be PEEP responsive, you're probably better off using the higher PEEP strategies, and that ARDS protocol is very reasonable and realistic. Yeah, and I'm not aware of any centers where people are routinely still, calculating lung compliance at various levels of PEEP. So I haven't seen it done for a long time. I don't know. We'll have to get another patient with ARDS and go over it again on the ventilator. So. Yeah. Other questions?
Yeah. The other question I had, unfortunately, we ran out of time yesterday. I didn't get to ask Dr. Gong. Was the what is your optimal oxygen level, or how low are you willing to go in terms of the patient's O2 sat, in terms of when you're actually going through this protocol and titrating up or down? When would you say, you say at 92%, you say, okay, great, we don't have to make any more changes, or is there any evidence, or just?
I mean, there is evidence. very good evidence that sats in 88 to 92% range are acceptable and non-detrimental. So I think that those are sort of the goals that are in the ARDSNet strategy. It's a little bit hard because everybody gets nervous. Like we talk about maps of 65. You can never keep somebody's map exactly at 65. So everybody's map ends up being 73, something like that. So there's a little bit of wiggle room. Similar with oxygenation. The respiratory therapist, nobody's going to stay at 88% consistently. If they're going to go down to 82, 84 at times, and up to into the 90s at times. So it's really hard to if you're saying 88% is your low limit, it's hard to keep people truly at 88%, and the respiratory therapist will never be comfortable with it. There is good evidence in healthy adults that very low oxygenation is well tolerated, and that has to do with the fact that your oxygen delivery is still adequate. If your cardiac output is decent, there's plenty of reserve there, and your oxygen delivery is still adequate even with a low oxygen saturation. So, I think it depends on the patient. In a patient that's clearly hypoperfusing, it's another story, and we might prefer to have sats at least in the 90s. But I would say that some people would argue that in an otherwise young, healthy patient, sats in the mid-80s are fine, or even lower. In Denver, right? Because your partial pressure is lower anyway. So all the trials, when they're done in Denver, they have to adjust them completely for their atmospheric pressure. But right, there's all that data on Sherpas and people who've climbed up to the top of Everest without oxygen and shown that they are okay. So I mean, those are healthy, obviously super healthy people. So it's different.
Just to add on the measurement of compliance, aside from using the graphs, actually you can calculate for it. So you can either calculate the dynamic or the static compliance, but the static compliance is the one that we use, and that's used for volume controlled, using like the exhale tidal volume over the plateau pressure minus the peak.
Right.
But if you're in the pressure control, you can measure the dynamic compliance. I mean, just to get an idea what the compliance is by measuring the exhale tidal volume over the inspiratory pressure, the peak inspiratory pressure minus the peak. So that's another way to do it.
Right, so it's not that difficult to plot out, but you have to think about it and plot it out. You look at tidal volume change with a given amount of pressure at different peak levels, titrating up the PEEP. One thing you would notice, for instance, in patients who are PEEP responsive, is when you add PEEP, their plateau pressure won't go up proportionately, whereas in patients who are non-PEEP responsive, who you're over-distending, when you add PEEP, their plateau pressure will go up more than proportional to the amount of PEEP. It's sort of the same thing. It's a less, scientific way to do it, but essentially that's what's going on. You want to be on what they call the expiratory limb of the pressure volume curve, or pressure volume curve. Yeah. So that's something you could do even without plotting it out. Look at PEEP, dial up PEEP, see what's happening with oxygenation, see what's happening with your plateau pressure as you're going up on PEEP at the same tidal volume. Sometimes we see that also after a recruitment maneuver, for instance, and that theoretically is what should have happened, is that the patient should be more compliant after the recruitment maneuver. So you've opened up, you've recruited alveoli, you've added to the overall compliance of the system. So sometimes you can see that after a recruitment maneuver if successful. So anyhow, anything else? Other stuff that we've missed? Salvage modalities. There's got to be other salvage modalities. ARDS. That's it? Yeah. Airway pressure release ventilation, which we talked about sort of as a salvage modality via, right, or bi-level ventilation. They're very similar. So that, generally what we're doing with the high PEEP strategies, with the oscillator, with the airway pressure release ventilation, is you're increasing mean airway pressure. So you're increasing airway pressure over time, right? A higher airway pressure over time generally in recruitable lung disease, it correlates with improved oxygenation. There is that issue about the time constant too, the amount of time it takes for alveoli to open. So things like the oscillator or the APRV clearly give a lot of time for alveoli to stay open. You'll see on the maquette ventilators also, they always have like an inspiratory, what do they call it? I forget what they call it, when they ramp up to a peak inspiratory flow instead of going straight up to it. I forget what they call it. Oh, right. So on assist control, we usually go straight. It's a square wave. If you see on the maquette ventilators, they'll never. They don't want to go to a straight up to a peak airway pressure. They'll ramp up to the peak airway pressure. I forget what that.
Ramp or decelerating?
Decelerating is another story as well. But they'll ramp up instead of ramping down, just with the idea that that's more physiologic. It gives the alveoli more time to open. So anyhow, sorry.
Have they looked at using PDEs for this?
Using
like the
phosphodiesterase.
Thank you.
Oh, so phosphodiesterase inhibitors.
Using it for like heart attacks and using it at altitude.
Right. So they tend to be good pulmonary. If we're talking about systemic phosphodiesterase inhibitors, they tend to be good pulmonary vasodilators.
Right.
That doesn't. It can have mixed effects on oxygenation overall. It may worsen that hypoxemic vasoconstriction. So the areas that are not being ventilated are not getting blood flow. So you may end up delivering blood to non-ventilated, non-oxygenated areas. Right. So on the other hand, if you're doing things like vasodilating the overall pulmonary bed, you may be increasing cardiac output, but some of them are inotropes and chronotropes. So you may be improving your oxygen delivery. So on the mixed venous side, things may improve a little bit. So you might be starting at a little bit better mixed venous saturation. So so it could go either way. But I don't know. I don't know of there good data on like milrinone. I think there is some data on it. Yeah. Yeah. I don't think it is a good therapy for like milrinone alone for refractory hypoxemia. It's a good therapy for pulmonary hypertension and for cardiogenic shock, essentially. But I think the effects overall on oxygenation tend to be mixed. So, okay. That was question one. That's good. I thought this was going to be too fast. Question two. So this is kind of a repeat. Anyone want to read it?
Which of the following treatment modalities have been shown to reduce mortality in patients with severe hypoxemia due to ARDS? High-flow oscillatory ventilation, prone position, inhaled nitric oxide, early administration of neuromuscular blocking agent, ECMO, none of the above, B, D, and E. So prone definitely does this. An EGM trial on citracurium is D. And E, I don't think E has ever been shown to reduce mortality.
Okay, yeah, it's arguable. I think anytime they say B, D, and E, it's like, why would they say B, D? I'll never do that on the boards anyway. I just felt like doing it. Anyhow, because it's not the board. Yeah, I would say G, but you're right. That's quite controversial. So if we look at all the trials, the oscillators, now there's enough data, I think, there's enough of a signal towards negative that you're not going to see a lot more or any more big trials coming out. I think it'd be hard to justify randomizing patients into the oscillator arm at this point. There probably isn't clinical equipoise at this point, and I don't think it would be approved. Maybe in another country. I have no idea. China, always look to China. Prone positioning. So now we have more positive data in addition to the sort of meta-analytic data suggesting in more severe ARDS that patients may benefit in terms of mortality reductions. Now we have this sort of like shocking result that nobody knows exactly what to do with, where there was a like a 50% relative mortality reduction in the prone patients versus the non-prone patients. Very similar trial to the prior trial done in JAMA 3 years earlier. A lot of the same centers were used. The protocols weren't all that different. They actually proned longer in the JAMA articles, the average of 20 hours. And that showed no reduction in mortality. So people are sort of shocked. They don't know if these centers have just learned to do this better. No idea. But people believe it. Nobody's doubted it yet. Nobody says it's complete fraud yet. So the data is much more positive towards proning. INO, we talked about chest oxygenation improvements that have been shown. That's the ACURA-Assist trial, the early neuromuscular blocking agents given early in patients with severe ARDS, right? Just for the first 48 hours, one trial showed a mortality reduction. ECMO is controversial, right, because what the CSER trial showed was referral to a center that's capable of ECMO. Showed there was a mortality reduction, and then when you looked at subset analyses, it looked like the patients who didn't get ECMO actually had the most benefit. So that just means everybody should come to Monty. Come to Monty. Pay us $200,000 to put a cannula in your neck rather than proning. Because we got to pay the prone people, right? We got to pay the company for that bed. It's expensive. Put a cannula in the neck. Right? There's no additional reimbursement for prone.
No?
There's no, it's not a procedure. There's no specific DRG for proning. So I don't see it. Somebody's got to get on a committee and make what self that we have it up there. We had it on consignment, but we didn't use it enough, so I think they took it away.
Where we have to for it now.
Use it or lose it. It was a rent-to-own situation. Repo man came. Anyhow, Franco, what's up? Right. So anyhow, we like ECMO. Seems to be our thing. Okay. Not necessarily bad. I don't know. Okay, this question I left here, I was going to take off, but when you look at the board reviews, there's still a lot of questions on the oscillator. I'm not completely sure they're going to take them off, and this is the most frequent question asked about the oscillator because it's the easiest one to miss. And it requires a little bit of an understanding of how the oscillator works. So if you want to just read it.
Sure.
Yeah.
Regarding high-frequency oscillating ventilator, which of the following ventilatory adjustments can be used to improve ventilation? Change in frequency from 5 to 3 hertz, decrease pressure, amplitude of oscillation, eliminate any endotracheal tube cuff leak, then all of the above.
Anybody? We can go over the oscillator. We can like briefly look at it.
I would guess amplitude.
Those articles and still I'm having confusion. I'm pretty sure it's not A, right? It can't be A.
Okay, we have one C. What's that? C? We have 2 C's. All right, so let's just look at the oscillator real quick. So I think the picture is, it's not that complicated, right? Okay, so this here is a bias flow. This is flow, okay? And this is an expiratory balloon valve that you can tighten or loosen to create pressure. So depending on how much flow you give and how you set this balloon valve, you're going to get a mean airway pressure, okay? So that's the pressure. The pressure, usually we set it at something like 30, okay? It's a pretty high pressure that's continuous going into the patient, okay? Created by this bias flow, all right? So blocking it here. You can imagine that, right? All right. Then here is this funny membrane that makes all the noise and makes it such a cool machine. It's just giving little pulsations, all right, little oscillations into here of pressure, okay? So essentially, what you set is and here's the patient with their ET tube, right? You set a power to be delivered to this diaphragm that's creating these oscillations and a frequency that these oscillations are given, okay? So you're setting bias flow. You're setting a goal mean airway pressure, which is how this valve gets adjusted. You're setting a power to be given to this membrane and a frequency for this membrane to beat at, basically. Okay? The power that you set is supposed to be adequate to achieve an adequate chest wiggle down to the level of the mid-thigh. Okay? So you're actually looking at the patient and you want to see that their thighs are wiggling. I'm telling you, this thing is cool. All right. So we know that there's such a thing as apneic oxygenation. It's not so hard to oxygenate patients without large amounts of ventilation. What's not well understood is how these patients are ventilated. Okay, not well understood. Diffusion, it's, I don't know, all stuff pulmonary people talk about. Pendula mechanisms, pendula phenomena, all sorts of weird stuff. Nobody really understands how these patients ventilate, but they do. I mean, they retain CO2, but you generally can keep them alive, generally. So, the things are, this question here is a kind of trick question, but they love it on the board. They used to love it on the boards. I don't know, they'll still put it on. This is the answer, it's A. So what happens at the same power if you decrease the frequency? What's going to happen to the amplitude? It's going to increase, okay? So those tiny little breaths become slightly less tiny if at the same power you decrease the frequency. The amplitude will go up somewhat, and that tends to improve your oxygen, your ventilation, okay? The goal overall is to have these patients as oscillatory as possible, so as high a frequency as possible, but when they're ventilating poorly, sometimes you have to decrease the frequency, getting them more towards conventional ventilation, essentially. It's not anywhere near conventional ventilation, because if you're saying if the frequency is 3, that's a respiratory rate of 180, as opposed to a respiratory rate of 300 when the frequency was 5. But still, it seems to improve ventilation when you decrease the frequency and thereby increase the amplitude. What's that? Well, APR, because APRV has an active release ventilatory phase, and so that ventilation is, that's where ventilation is thought to occur, and ventilation tends to be less of a problem with APRV. It's a lot more lung movement. Think about it. The tidal volumes right. It's similar. You're creating this continuous airway pressure, a high mean airway pressure over time. But there's lung movement. There's a difference. And the movement can actually be large. The tidal volume can actually be large in APRV. So there is some difference. In a way, it's the complete opposite at the same time, because you're only breathing at a few times a minute, right? It's this big release and this big reinflation. So in a way, it's very similar. In a way, it's quite different. And then the other thing you can do is usually you need to actually have a little bit of a cuff leak for CO2 elimination, which makes everybody nervous, but it's just needed. You need to deflate the cuff a little bit. Anyhow, it's an interesting mode. The patients don't all need to be paralyzed. A lot of patients will become apneic on it without paralysis, actually, which is very interesting if you think about it. As long as your pH is normal and your PaO2 is normal, some patients just become apneic. Right? If you're asleep and you have a normal pH and a normal PCO2 and a normal oxygenation, there's no real drive to breathe there. So some people need to be paralyzed, but not everybody. Okay. Oh, so this was we kind of done this already. We've done almost everything in the first question, which was good. But I'll read it. Which of the following vasoactive drugs is most likely to worsen intrapulmonary shunt in patients with ARDS? So A is intravenous phenylephrine, B is intravenous prostacyclin, C is aerosolized prostacyclin, D is inhaled nitric oxide, and E is none of the above. We sort of talked about
IV prostacyclin?
Right, so IV prostacyclin, right? So a sort of a systemic pulmonary vasodilator tends to worsen shunting. It may have mixed effects on oxygenation overall. It is something to think about, though. You know, we could put patients, it's pretty rare that patients in ARDS need to be put on systemic vasodilators, but I have seen their hypoxemia get worse when they have to be. So, you know, IV nicardipine, IV nitroprusside, these types of things, they've clearly been shown to worsen oxygenation in patients, and it's something to think about. Don't get in that scenario too often, but something to think about. And IV neosynephrine of the pressors seems to accentuate pulmonary hypoxemic pulmonary vasoconstriction more than others and may improve oxygenation in some studies, which is kind of counterintuitive stuff. This is a new one. I'm going to start reading them just because I want them to be we're taking too long. Given the very profound reduction in mortality demonstrated with the use of prone position ventilation in moderate to severe ARDS in the PROSEVA trial, that was that latest proning, the positive trial, which of the following reasons may limit the rapid and widespread adoption of this practice? This is another one that would never be on the board. I just put it there. A, concerns about efficacy versus effectiveness. Safe and effective use may require years of training and experience. B, concerns about efficacy versus effectiveness. More than 4/5 of patients with ARDS were either not screened or deemed ineligible for the trial. C, concerns about confounding. A higher percentage of prone patients receive neuromuscular blockers. Or D, all of the above. Okay. Words like concerns, that's always good, you know, like in the long. Anyhow, so right, so all of the above. So efficacy versus effectiveness, I think, is important to talk about. Dr. Gong will probably talk about it some, but efficacy is how well in an experiment something is shown to work, and effectiveness is how well something works in the real world. And we've seen huge gaps between these two, particularly in critical care in recent years, right? So if you looked at the initial tight glycemic control trials, for instance, where they put patients on 80 to 110, they controlled the patient's blood glucose to between 80 and 110 very strictly versus a more loose control arm. The initial trial showed a large mortality reduction. It became a big deal. All sorts of federal safety agencies started insisting on it. Hospitals were putting it into their protocols. We put it into our protocols. Everybody was insisting on it. And then people started to look at what was going on with their own data. I looked at what went on with our own data on, this is where things like clinical looking glass are useful. And they saw that in the real world, the mortality, hypoglycemia rates went way through the roof and mortality rates went up. And then when they repeated the studies in a less controlled setting, not in one center that specifically focuses on this and is so good at this, they showed mortality increases. So I think it's important to think about when you're thinking about an intervention that's sort of as complex and potentially dangerous as this. Proning is one of those where there's clearly a learning curve. You know, the 2010 article showed no difference. All of a sudden by 2013 they're cutting mortality in half. I don't know. So I kind of feel like it's one of those things we should either be adopting pretty widely, you know, pretty liberally in the patients that it's appropriate on, patients with severe ARDS who are clearly salvageable otherwise, you know, within the first, you know, day or so. We should really be thinking about it, or we should just not be doing it, because you don't want to be the first or the second or even the 20th patient prone to monofure necessarily. So the other thing were that when I looked at the trial, a lot of, and this happens with all RCTs, but they usually do a better job of describing why patients are deemed ineligible for the trial. That's usually a big deal, because otherwise people call it just a convenience sample. So you want to know why 4/5 of the patients were either not screened or deemed ineligible. Mostly they were just not screened. But did they not screen them because they said, oh no, that patient's too big, we'd never prone them anyway, or oh no, that patient probably do terribly with proning, or, you know, who knows. So this was clearly a select subpopulation. And then confounding, is an issue here too. I don't think that the neuromuscular blockade effect could explain the 50% reduction in mortality, but definitely a lot more patients who are prone were paralyzed initially, and we know that that may improve mortality, right? So there's another independent variable that may confound the primary outcome, basically. Okay, cases. 70-kilo man, cirrhosis, polysubstance abuse, comes in, has a massive aspiration event, has distributive shock and ARDS, sedated but asynchronous with a ventilator, tachypnic to 32 breaths a minute. On PRVC, set at 12. Again, breathing at 32 though, tidal volume 450, PEEP of 12. The blood gas is 732, 2658, with 86% sat and a lactate of 8. You want to improve oxygenation and give the patient vecuronium. The patient's sat improves somewhat after a couple of minutes, but then a couple of minutes after that, the patient has an asystolic arrest. Peak airway pressure is not so bad. It's 27. Any thoughts on where you might have gone wrong here? So all we didn't make any other changes on this ventilator. We just paralyzed the patient.
Acidotic, respiratory acidosis.
Okay, the patient did, right? Right. So this is something that gets missed in the ED all the time, and that I don't think we should miss, is that patients who are very sick have a high minute ventilation for a good reason. You know, a lot of it is compensatory. This patient may have a lot of dead space and may be very acidotic for other reasons, and may need to eliminate CO2. So whenever you see a patient like that that's super tachypnic and working really hard and you paralyze them, you need to approximate their prior minute ventilation. Okay, so when you're paralyzing the patient, you're taking their drive away completely and their ability to compensate. So you need to go up on at least the respiratory rate, right? So this patient, you know, they didn't necessarily need to be set at 32, but when they got paralyzed, they needed to be set at 22, something like that. So I've seen a number of patients who, after getting paralyzed, their next blood gas, the pH is 6.9 range. 28-year-old female, sickle cell disease, hyperacute hemolytic crisis, acute chest syndrome, progresses severe ARDS. The decision is made to put her on the oscillator as the first salvage modality. You do a recruitment maneuver, but during the maneuver, her O2 sat drops from 90 to 70%. Any thoughts on things to do here? If you're going to put somebody on an oscillator, before you put it on an oscillator, you're supposed to recruit them, generally. Yeah, probably, right. So, right. So she could have a pneumo. You know, she might be just not recruitable, not really tolerating the high PEEP. And that's an indication, you know, the PEEP of 30 that you have her set at, that's where your pressure is going to be continuously on the oscillator. So it tells you that she may have a pneumothorax. That's true. Even if she doesn't have a pneumothorax, she's probably not going to do well on the oscillator because she desaturated so profoundly when you put her at the higher airway pressure. So it's probably not the solution for her. Someone you would expect it to be, but we're not always right about that. Any other things we could do? So let's say we're saying, okay, we do an ultrasound, there's no pneumothorax, but we're not putting her on the oscillator, we're going to do something else for her. So ECMO would probably be reasonable for this lady. Anything else specifically for patients with sickle cell disease? Exchange transfusion would probably be a first-line therapy. I didn't really talk about it here, but transfusion and then exchange transfusion. Inhaled nitric oxide, right? Right. So patients with sickle cell disease tend to have pulmonary hypertension. When they hemolyze, the free hemoglobin binds to endogenous nitric oxide. So their endogenous nitric oxide levels tend to fall very low. So we know that these patients respond to nitric oxide in terms of oxygenation acutely, Whether, it makes any outcome difference, we don't really know. But it's something we think about very frequently in patients with sickle cell crisis who are in ARDS. Their pulmonary pressures will likely come down and their oxygenation will likely improve, at least in the short term. So that's what you do. You put her on INO and you get improvement in her. This was a real case that this was based on. You got improvement in her oxygenation. You're all very excited. And 3 days later, she's hemodynamically stable, but with a good oxygen saturation. But you can't seem to titrate her INO down. Her blood gas on 60% oxygen is 7.32, 28, 74, 12, and 95% with a lactate of 12. So hemodynamically stable, saturating well on INO for a while, but now with a lactate of 12. Any thoughts? It was mentioned early on, very early on. So what do we worry about with long-term inhaled nitric oxide? Right, and it meant hemoglobinemia, right? So that's what happened in this case, actually, and we see a couple of cases a year, whether it's, after a bronchoscopy or somebody that's on INO, that they get significant hemoglobinemia. Right. So you have to stop the INO. You can try elafrosia. You can try something. If it's severe, you have to give them methylene blue, which we talked about before. I don't remember if I don't think we gave this lady methylene blue. I think she got better off of INO. Yeah.
Usually they say it's
I think she was at higher levels, and whenever we kept trying to titrate it down, we would always have problems. That's where they started usually. Yeah. Called by a physician at a community hospital consider for transfer to Monty for potential ECMO, and this was a real case too. It was one of PA's uncle, 68-year-old male, severe, progressively worsening ARDS, thought to be a hypersensitivity reaction to INH. He's been intubated for 4 days, and his course has been complicated by need for transfusion of 6 units of red cells due to retroperitoneal bleeding after femoral central line placement. Latest blood gas on pressure control, rate of 24, FiO2 of 55%, a PEEP of 14, pressure of 14 above the PEEP was 7.28, 52, 65, and 24. Hemodynamically stable.
Why is the need for ECMO?
Right.
You're doing well.
Right. Yeah, no, I think I would agree with that.
I'll be happy to take them.
Right.
But I'm not going to go by the ECMO.
Right. So this was a CT surgeon's PA's relative, and we did bring him over, and they were very hot and heavy to put him on ECMO. And why would you be particularly concerned about it in this patient? Because of his bleed, right? An uncontrolled bleed, you're going to have big problems with bleeding on ECMO. And all of our ECMO that we use, whether it's VV or VA, requires very significant anticoagulation. So bleeding is a major complication that we have reported with ECMO. So right, you're doing pretty well. Doesn't mean the patient shouldn't come over to Monty and be managed, but anyhow. What do you give steroids? I don't think they help. Didn't help. All right, last case. 35, I'll go to two parts. 35-year-old morbidly obese female presents to the ED with severe ARDS from influenza A. She suffers a cardiac arrest in the ED due to difficult intubation and prolonged hypoxemia, but she has return of spontaneous circulation after 7 minutes of CPR. Because of ongoing hypoxemia, she's emergently placed on VV ECMO. She's on PRVC rate of 12, tidal volume of 420, PEEP of 14, FiO2 of 55%. Her peak airway pressure is 39. Her first blood gas on ECMO is 7.37, 41, 140, 23, and 99%. Anything anyone would do on her ventilator? Or okay, so Perminder is saying to decrease the tidal volume. I think that would be what I would be looking for here. So one point of putting people on ECMO is to put them on lung rest, right? So nobody knows what the lowest tidal volume, tolerated is. Most people don't think that giving no tidal volumes is a good idea. So, but we put people down to 4 cc's, 3 cc's per kilo is probably fine. We don't always get adequate oxygenation with ECMO. Sometimes we need 6 cc's per kilo and higher FiO2s. Here you're getting adequate oxygenation. Ventilation is almost never a problem with ECMO. You can eliminate carbon dioxide very easily. So yeah, so we should be putting patients on lung rest essentially as much as we can. And I don't know, has that been, well, we haven't been doing ECMO for ARDS recently. We've been doing ECMO for other reasons, right? It's not the winter time. It happens more in the winter time.
Oh, for ARDS?
ARDS, not recently. BV ECMO, the young man. You have one now?
Yeah.
In the MICU? Oh, the CTICU at a BV ECMO for ARDS?
Yeah.
And what sort of tidal volumes do we have the patient on?
Oh, she's low. Like in the 400. Actually, she's a little bit higher. Actually, I think she was 450 when I looked at her left.
Okay. And do you know what that is in per kilo? Like how
no. So it's gonna be a little over 6 actually.
So I'm going to think about it. If you're able to oxygenate her, you can deal with the carbon dioxide.
Yeah. At the lower end of the. It's getting a little tough. I mean, she's about to die. Actually.
Oh, okay. That makes it more difficult. So,
yeah.
And you guys know we don't always do. We're not always able to. The ECMO's circuit's not perfect. BV ECMO for oxygenating patients. So depends on the placement. Depends on So you may need a regular 6 cc per kilo tidal volume if you have some room.
Make your bed.
Dr. Keene.
Yes.
Dr. Keene. So
yes.
why wouldn't you
Go down it.
if you go back, why wouldn't you go down the PEEP? I mean, what do you stand to benefit from a PEEP of 14 if your PO2 is like 140 and her gas exchange is okay? Because if you go down the PEEP2, it may help with the venous return and decrease the airway pressures as well.
Yeah, I think that would be fine too, to be honest. I think it would be fine. Some people prefer some PEEP be kept there if you're talking about, keeping her, thinking that she may be more compliant with a little bit higher PEEP. So I think it would be okay to come down on the PEEP and see what happens with her airway pressure.
You would think they could do it. They have to. Okay. No, they could.
Because she's essentially like, and I don't say that she's paralyzed here, but she's synchronous with the ventilator. So her peak and plateau pressure are probably the same. It's probably about in the high 30s for plateau pressure on PRVC. So, and we don't know because she's obese also what actual, we don't have an esophageal probe in. So what is the actual pressure being felt by the alveoli? That's a question still. But the peak airway pressure. What's that?
She's morbidly obese, right?
Right. So it may not be that her airway pressure is really, that her alveolar pressure is too high. It's hard to know without an esophageal probe in. So, so I think that either lowering the tidal volume or lowering the PEEP would be, you could argue about either of them. But is there a reason that you would rather lower the PEEP than lower the tidal volume?
I mean, not, I don't know if a CCC per kg in ECMO would hurt her. And, you have enough oxygenation,
right.
Your ventilation is okay. So if you're starting to peel off stuff, I would rather take off the supernormal PEEP first. Okay.
I think that's very arguable. Could go either way.
Why don't you just go down, whichever you go down on, whether it's tidal volume or the PEEP, and just adjust the ECMO
right.
to give you better
CO2 elimination. You can do that. Yep. You can do both.
Okay.
Okay. So this is I thought this was a fancy question, and then wasn't going to ask it, but then I actually found it on a board review, something very similar. So. But it's kind of interesting. It's not really all that pulmonary related, but anyhow, she's it is also very realistic. This is what happens not that infrequently in our patients that we put on ECMO emergently. They've had some sort of arrest. They're young. They've arrested from hypoxemia. And in the heat of the moment, we don't know what to do, and we put them on ECMO to stabilize their cardiopulmonary status, right? So that happens to her over the next 3 days. She's normothermic, normotensive, renal function is okay, no other metabolic derangements. But off all sedation, she's unresponsive and has no brainstem reflexes to our basic exam. Her head CT shows diffuse edema. So this is not, I don't know if you guys have had to deal with this yet, but this is not an uncommon occurrence in patients who've been placed emergently on ECMO that they've arrested, and we don't know where their mental status is going to end up. Okay, but here we are 3 days later with no brainstem reflexes. So what would you do? How do you deal with this? Do you declare her brain dead based on your exam with no brainstem reflexes? Do you perform a classic apnea test, a modified apnea test, or a radionucleotide brain perfusion study? Okay, so Parminder's is saying a modified apnea test. And how are we going to do that? A modified apnea test?
So if we do the usual thing, her CO2 will not rise because she's an ECMO, she has a circuit. So you will have to turn the sweep to 0.
Okay.
So she's not clearing CO2, but she's oxygenating. And then we will do the apnea test.
Right, right. So this is, I was surprised this was a board question. When we faced this issue like 9 months ago and came up with this answer, and we looked through the literature, and it clearly had been described in some cases. It's not a part of any apnea protocol, but it makes sense physiologically that you do it, right? So, so people are going to be uncomfortable with it. The perfusionists are always very uncomfortable with all talk about withdrawal of the machine and all of that. But they can do this, and it's actually, if you think about it, sort of in terms of hemodynamics, a safer way to do an apnea test, right? Because the patient's not going to desaturate or shouldn't desaturate, or they're less likely to desaturate than with a classic apnea test, okay? So all you do, like Parminder said, is get rid of the carbon dioxide sweeps. And so the PCO2 is going to rise. You do the same thing. Check it 4 and 8 minutes or 5 and 10 minutes and make sure the PCO2 has gone up adequately. And that's perfectly acceptable.
Is it really called modified apnea?
That's what they called it on the board exam. I'd never seen it described, and I thought that that was a bad way to state it because you should describe what I've never, we could Google modified apnea test. I don't think that, I'm not sure that that's a term that's well understood. But that's his brain experience. Go straight to Google contact lens. I don't know. Anyhow, right. So, that's one thing about apnea tests. I think we need to remember that it's just testing for a respiratory drive in the face of the most profound stimulus to breathe, which is what pulmonologists will tell me. Pulmonologists will tell me, and I'll argue with them. What's that? See, I'll argue with them every time. Right. Don't think it's hypercapnia. I think that's secondary. I think there's something else primary to hypercapnia. We could ask Mark Milstein. What else is there? Acidosis, right? I think it's acidosis. If you did an apnea test on somebody who's a CO2 retainer, a chronic CO2 retainer, and their bicarb is high, if you make somebody alkalotic and then do an apnea test on them, their CO2 rise won't make them breathe. It's when they get acidotic that they'll breathe. I think that's prior. There is a drive to breathe for CO2. But if you think about CO2 retainers, they have high CO2, and until they get acidotic, they don't have a drive to breathe. We'd say they've gotten used to it. But nobody, well, some people get used to acidosis, right? That's the rare circumstance, but occasionally you'll see that patient who doesn't have much of an acidotic drive to breathe either. And then tertiary is probably hypoxemia, right? So, okay.
So you will never go for, so D can be false positive sometimes, or is it always going to be false positive on ECMO?
D, I'm not, first of all, very difficult to do on ECMO or impossible. I'm not sure that we could do it on ECMO. The problem with D is that it really an apnea test is still a more specific test overall, so we should use it. There can be some patients that radionucleotide exam doesn't image the brain stem as well. There's talk about that, you know. So we should still, if we can do the basic test, the most basic test, the apnea test, that's what we should do. It's not like these other tests are better. We just go to them when we have no other choice. So that's the same with the EEG, same with the with cerebral angiography. You know, the CAT scan alone is very concerning. Our exam is very concerning. If we can do an apnea test, that should be good enough.
The first citing I get is a neurosurgical group in 1992 from the University of New Mexico. They state that, like at that point, PaCO2 of 60 millimeters mercury above is traditionally accepted as a respiratory criteria for determination of brain death. But they're saying it's pretty hard to accomplish that in everybody. So therefore, they take 11 patients who met everything but the respiratory criteria for brain death, and they used a modification of a previously utilized apnea test protocol, so that they were brought to a PaCO2 of 40 millimeters mercury or above prior to the apnea test. Baseline PaCO2 ranged from 40 to 45 millimeter mercury in 6 patients and 46 to 51 millimeter mercury in 5 patients. So the mean, basically, they got mean PaCO2 of 5 millimeters mercury or 7 millimeters mercury, and then they basically say that there are no problems with cardiovascular instability or hypoxia, and they're saying that this is their, so they're not bringing it up as much, basically.
So they just kill people, basically. They're like, I'm sick of trying this apnea test.
Yeah.
Let's just change our criteria. That's what they're saying.
Yeah.
Right? Anyhow, yeah. So that, I don't think that's what they're talking about here, but that would be one way to modify it. Change your criteria. So, anyhow, it's interesting. But that wasn't based on ECMO.
But like everybody else in the Google thing, they're all quoting that 1982 paper.
Yeah. There's definitely descriptions of this of stopping the sweeps on ECMO. There's from the center in Michigan where they do tons of ECMO. They've described it. A few centers have described it. I haven't seen it referred to as a modified apnea test. But we did it. We've done it twice here now and used it to confirm brain death in removed patients based on that. So. Okay. That's it. That's all I got. Done. Finished. Thanks, guys. Other questions? Weiler? Einstein? Any Einsteins out there? Einstein?
No, we're good.
You're good. All right. Thanks.
Thank you.
Thank you.
I have a question for Dr. Keene.
Yes.
So yesterday, again, this is based on yesterday and today.